Assalamu alaikum. Bismillahirrahmanirrahim. My task is to teach you virology, and I will cover these topics related to virology. But before starting, I want to introduce myself. I am Dr. Asif. I did my MBBS for IMC and MCPS in medicine, FCPS in cardiology. I am assistant professor in cardiology from 2016 till date in Khyber Medical University. I have completed all supervisory and BLS courses. I also have a diploma in health profession education from Khyber Medical University. I have 18 research papers in cardiology in PMDC approved journals, and I'm the only cardiologist with research data on local cohort population. I have been involved as examiner, as a module director, and I'm the only PMDC approved supervisor for house job and FCPS trainees in cardiology in cohort. So let's start with today's lecture, which is approach to a patient with a suspected infection. Whenever we come across a person with fever, we always think that he is or she is having an infection. But generally speaking, every fever is not infection, and every infection is not fever. Infectious diseases can affect any organ or system and can cause a variety of symptoms and signs. Fever is often recorded as the cardinal feature of infection, but not all febrile illnesses are infections, and not all infectious diseases present with fever. History taking and examination should aim to identify the site of infection and also the causative organism. A detailed history is taken with specific questions about immunological risk factors for infections. These are based on the sources of infection and route of transmission as discussed. Travel history, which is important in those who are traveling. Some diseases are more prevalent in certain geographical locations, and many infections common in the tropics are seen rarely, if at all, in the UK or the developed world. Food and water history. Systemic as well as gastroenteritic infections can be caught via food and water. Occupational history is also important for catching of infection. For example, hunters will have zoonotic diseases. Animal contact history is important for domestic, farm and wild animals, which can be responsible for zoonotic infections. Sexual activity as well as the traditional sexually transmitted diseases HIV, hepatitis B and rarely hepatitis C can all be transmitted sexually. Some enteric infections are more common among male homosexuals. IV drug use as well as blood-borne viruses, drug injections are susceptible to a variety of bacterial and fungal infections due to inoculation, tattooing, body piercing, and receipt of blood products, especially in the carefree blood transfusion centers, are also risk factors for blood-borne viruses. Layer activity like water sports may lead to waterborne infections or zoonosis. A thorough clinical examination that covers all systems is required. Skin rashes and lymphadenopathy are the common features of infectious disease, and the ears, eyes, mouth, and throat should also be inspected. Infections will produce a rash sometimes, and rectal, vaginal, and penile examination will be required in sexually transmitted infections. Fever pattern may be occasionally helpful. For example, tertian fever of falciparum malaria, but too much weight should not be placed on the pattern or degree of fever. So as we said that the pattern of rash like macular and maculopapular rash can be in viral infections and some bacterial or rickettsial infections. These include measles, rubella, entero, human herpes, Epstein-Barr, cytomegalo, erythrovirus, HIV, dengue, typhoid, secondary syphilis, and rickettsial spotted fevers. Vesicular rash is seen in chickenpox, herpes zoster, shingles, herpes simplex virus, hand, foot, and mouth disease of Coxsackie virus, herpangina caused by Coxsackie virus. So, whenever you come across vesicular rash, it is most probably viral. Petechiae and petechiae or hemorrhagic spots can be seen in meningococcal septicemia, any septicemia associated with disseminated intravascular coagulation, rickettsial infection, and in viral infections. Erythematous patches can be seen in scarlet fever, Lyme disease, toxic shock syndrome, and erythrovirus B19 infection. Urticaria is a feature of toxocaria, strongyloides cercoralis, schistosomiasis, and cutaneous larva migrans. So, how would you investigation? How would you do investigations in a patient with suspected infectious disease? Sometimes they are not required, but in some infections they may be needed. In some infections like chickenpox, clinical presentation is so distinctive, so clear that no investigations are normally necessary to confirm the diagnosis. Other causes might require investigation for confirming the diagnosis. So, which investigations should be taken? These include blood investigations, imaging investigations, and some advanced radionuclide scanning. Routine blood tests include complete blood count, ESR, C-reactive protein, biochemical profile, urea and electrolytes, and most often they suffice and diagnose the case. Imaging like X-ray, ultrasound, echocardiography, CT and MRI scanning are used to identify and localize infection. Positron emission tomography and single photon emission computed tomography have proved useful in localizing infection, especially when combined with CT scan. However, the sensitivity that is the ruling out of the disease and specificity that is inclusion of a specific problem in diagnosing infection has yet to be determined, and the use of these imaging modalities remain limited. You can also do biopsy or aspiration of tissue for microbiological examination that is facilitated by ultrasound or CT guidance in deep tissues. Radionuclide scanning after injection of indium or technetium labeled white cells which were previously harvested from the patient may be occasionally helpful in localizing infection. It is most effective when the peripheral blood cell count is raised and is of particular value in localizing occult abscesses. So what if neutrophilia turns out to be on full blood count If there is neutrophilia, most likely there is bacterial infection. Neutropenia can be associated with viral infections, brucellosis, typhoid, typhus, and overwhelming sepsis. Lymphocytosis indicate viral infection. Lymphopenia is HIV infection but not specific. Now, COVID infection has also been said to be associated with lymphopenia. Atypical lymphocytes can occur in infectious mononucleosis. Eosinophilia is a feature of invasive parasitic infection. Thrombocytopenia can occur in overwhelming sepsis and malaria. ASR or C-reactive protein is elevated in all infections. Urea and electrolytes are deranged when there is severe illness. Liver enzymes may have minor elevation of transphorases, non-specific feature of many infections. There might be mild viral hepatitis leading to minor elevation of transphorases. High transphorases with elevated bilirubin indicate that patient is having viral hepatitis, most commonly A, B, or E virus. Coagulation may be deranged in hepatitis and in overwhelming infection of any type. So, what are the microbiological tools for diagnosing an infection? That might range from simple microscopy to molecular probes. It is often helpful to discuss the clinical problem with microbiologists so that appropriate tests are performed and specimens are collected and transported correctly. Microscopy and culture specimen to be sent for microscopy and culture in macular or maculopapular rash of measles, rubella, and enteroviruses. So when you are sending blood, you will send for James stain for malaria. An indication would be any symptomatic traveler coming from a malarious area or a person living in an endemic area with fever. Stains for other parasites have specific indications for specific tropical infections. Culture is done for all suspected bacterial infections in the blood. Urine is used for microscopy and culture for all suspected bacterial infection, and tuberculosis culture is done if there is suspected TB and the leukocytes in the urine are unexplained and coming up repeatedly, then TB culture is required. Feces microscopy plus iodine stain is used for protozoal diarrhea. Culture of the stool for all unexplained diarrhea. PCR or antigen detection is usually not necessary to do both. You do either PCR or antigen detection and you can check for suspected viral diarrhea. Clostridium difficile toxin in stool, and the indication is the diarrhea when patient is admitted and is on antibiotic therapy. Throat swabs, culture, PCR, and rapid antigen detection are usually done for tonsillitis, pharyngitis, PCR for viral meningitis, and PCR or antigen detection for viral respiratory infections where urgent diagnosis is needed. Sputum microscopy and culture is usually not done in routine infections, but unusual chest infection and pneumonia might lead to this testing. Sputum or amine stain RTP culture, liquid culture may be done for suspected TB on sputum sample. Other special stains or cultures are for immunocompromised patients and for those where we suspect that there might be a fungal infection, like for example immunocompromised patients. CSF microscopy and culture is done for suspected meningitis. Autoimmune stain or TB culture is done for suspected TB and meningitis. Other special strains or cultures are done for immunocompromised patients and suspected fungal infection. PCR for suspected encephalitis or viral or bacterial meningitis. Rash aspirate petechial microscopy and culture for meningococcal disease and vesicular rash. If there is there, you do the aspirate and then do PCR or antigen detection for herpes simplex or herpes zoster virus. So how would you treat an infection? Many infections, particularly that are caused by viruses, are self-limiting and require no treatment. The mainstay of treatment for most infectious diseases is antimicrobial chemotherapy, but the choice of antibiotics should be governed by the clinical state of the patient, the likely cause of infection. Serious infections may require supportive therapy in addition to antibiotics. It is always preferable to have a definite microbiological diagnosis before starting the treatment so that an antibiotic with most appropriate spectrum of activity and site of action can be used. However, some patients are too unwell, so we cannot wait for results, and in this case, the culture may not be awaited because culture may take days. These diseases like meningitis or septicemia may be fatal and therapy must be started on an empirical basis. Appropriate samples of our culture should be taken before the first dose of antibiotic and an antibiotic regimen chosen on the basis of most likely causative organism. Usually patients are Usual patients are less unwell and specific therapy can be deferred pending the results. So that is it on the general aspects of infection. Thank you.